So that was a lecture that I gave in the session of post-neoadjuvant treatments, and my task was to talk about HER2 positive disease. So I discussed about escalation and de-escalation strategies. In the de-escalation strategies, there are possibilities of checking patients with pathologic complete response and see whether they need less treatments. This is the concept behind. Ideally, even in the patients who have a pathologic complete response after the neoadjuvant treatments, chemo, anti-HER2 drugs, we can divide these patients in what we call high risk for relapse and low risk for relapse. So within this group, we need to refine who are the special candidates for the escalating strategy and which is the best strategy. So today, we have a few trials that are ongoing to look for this. For instance, the COMPASS trial in the United States, North America. So they are looking for a short treatment with taxane and Pertuzumab, Trastuzumab. If the patient reaches pathologic complete response, they will continue on anti-HER2 drugs to complete 1 year, so no further chemotherapy. So in this sense, you can decrease the chemotherapy and they reach pathologic complete response. Another similar strategy is the DECRESCENDO trial. It's running in Europe and Australia. And this trial is a similar concept. They receive taxane with Pertuzumab, Trastuzumab, but here the population is only hormone receptor negative, lymph node negative, and tumors between 1.5 and 5 centimeters. So these are patient population that can respond well to pathological to the treatments and have a pathologic complete response. And then, if they reach the pathologic complete response, they receive only the anti-HER2 drugs to complete 1 year. So in this sense, you de-escalate. Another strategy that I presented was tested in a Spanish trial, the PERGAN trial. That was a very interesting trial in the sense that one group that was called the group B, they would start with anti-HER2 drugs alone or with endocrine therapy if they were hormone receptor positive. So they receive this treatment for 6 weeks. Then they have a second PET scan to see the response. If they are considered responder according to the PET scan, those patients would continue with anti-HER2 drugs plus minus endocrine therapy according to their hormone receptor status. And then they would go for surgery. And then if in the surgery they had a pathologic complete response, meaning no tumor and the operatory tumor, they would continue on anti-HER2 drugs alone, Pertuzumab, Trastuzumab. So it's a small group, 86 patients, that are completely chemotherapy-free. They were never exposed to chemotherapy. But this assessment was based on the response to the treatment according to the PET scan and then according to the pathology results. So it's very interesting. They showed the results now with a 3 years invasive disease survival is a very good outcome for those patients. So there is still a subset of patients they will not need chemotherapy, though they are more responsible to anti-HER2 drugs. That was very nice. And then there is also the I-SPY trial that they are looking for using imaging, biomarkers, and testing new drugs. If the patient reaches pathologic complete response, they would continue anti-HER2 drugs. So there are different strategies. What I showed as well was the HER2-DE, that's a genomic signature that can look into separate those patients, even with pathologic complete response, those who have an excellent outcome, you never relapse, with those that have a pathologic complete response, but they still relapse. And this is very interesting. So this is being tested prospectively. They had a lot of retrospective studies, and this is going to be very interesting. So if you can discriminate those patients, because this is important, because you know today that pathologic complete response is good for the patient, but does not necessarily mean the patient will never experience a relapse. And this you know from pooled analysis that when you have the pathologic complete response, and if they had positive lymph nodes or if they had large tumors, the outcome is not the same as if they had node negative and had a pathological complete response. So in the de-escalation area, there are a lot of strategies nowadays. We still need to identify the best patients to shorten this duration of treatment or to decrease the anti-HER2 drugs to one drug alone. We do not have this answer. What we know that for the escalating, and I didn't spend much time in the presentation on that, today you use much less anthracycline chemotherapy to those patients. You can use taxane with Pertuzumab, Trastuzumab, or you can use docetaxel carboplatin, so we reduce the anthracycline. And this is based in two trials, the BCRG-006 and the TRAIN2 trial. We know that there are some strategies to look into to decrease the total duration of anti-HER2 drugs. Because when we started using Trastuzumab, 1 year duration was the established duration, the best one. But then people started saying, what if you give only 6 months, or if you give 3 months? And then they had different trials testing this, at least 5 randomized trials, looking for non-inferiority of short durations to 1 year duration. And all trials failed except the Persephone trial. That was a UK trial, a large number of patients. Here they could demonstrate that 6 months was non-inferior to 1 year, but when you look at the subgroup analysis, you know that patients who had more disease or had concomitant anthracycline taxanes, they do benefit from 1 year. So today the strategy of 6 months is not used, so everybody uses at least 1 year duration. This was for the de-escalation. For escalation treatments, there you have several strategies for escalating. How can you escalate? So the first treatment for HER2 positive disease was 1 year of Trastuzumab. Then you escalate with 1 year Trastuzumab and Pertuzumab on top of the chemotherapy based on the affinity trial. And this trial showed that the node positive population, they derive the most benefit of this strategy. The node negative population does not derive any benefit. And the benefit is also independent of the hormone receptor state. So hormone receptor positive, hormone receptor positive. So today, patients with node positive disease, we give 1 year of Pertuzumab, Trastuzumab as well, can start in the neoadjuvant and continue in the adjuvant if they have pathological complete response. But we knew that some patients, when you treat in the neoadjuvant, we discussed the pathological complete response, but we also have a group of patients, they have residual disease. They still have cancer after the neoadjuvant treatment when you operate the patients. And these patients, they have a worse prognosis, a worse outcome, more chance of relapse. And this was tested in the KATHERINE trial, was the first trial to escalate treatment in patients with residual disease. So the KATHERINE trial took patients treated HER2 positive disease, treated with chemotherapy and anti-HER2 drugs. Most of them, they were treated with Trastuzumab alone, 20% with Trastuzumab, Pertuzumab, or other dual blockade. And if a patient had a residual disease, those patients, about 1,500 patients, they were randomized to receive TDM1, that was the experimental arm, 1 injection every 3 weeks for 14 times, or to continue with Trastuzumab, that was the standard of care at the moment, 1 injection every 3 weeks for 14 cycles as well. And what they showed now, they presented in San Antonio last year, the latest results, they updated the IDFS and the overall survival results. What they showed that at 8 years follow-up, we still continue seeing an improvement by 13% in invasive disease-free survival, meaning that the patients, they relapse less when they use the TDM1 compared to Trastuzumab. What was interesting to look in this IDFS, the node-positive population, even if they derive benefit from TDM1, they still do badly, so we need to improve in this patient population. And those patients, we always thought, okay, you're going to give more and they're going to have less brain metastasis in those patients because this is a concern in this patient population. But there you didn't see a decrease in brain metastasis. That was the first part of the IDFS, but then they showed the most important, that is the overall survival benefit from TDM1. So they looked into this 80 years, at 80 years, they see a 3.7% absolute benefit in overall survival. So patients are dying less because of TDM1 compared to keeping on trastuzumab. And this for us was a big improvement because it really shows that having residual disease is aggressive, but we can improve the outcome of those patients. So this strategy is a standard of care, is recommended in all guidelines. Patients treated with neoadjuvant chemotherapy, operated, and with residual disease, today the standard of care is TDM1 for 14 cycles. So these all guidelines recommend that. There are other strategies they are looking now, is to whether TDXD, trastuzumab deruxtecan, that has been shown to be better than TDM1 in the metastatic setting, second line. They are testing now in the post-neoadjuvant. Same concept of KATHERINE. We have the Destiny Breast 05. They are looking head-to-head comparison, TDXD versus TDM1. And then we are expecting results next year. And if you prove, maybe you can improve even further the outcome of patients. There are other strategies in North America in the COMPASS RD trial, looking to adding tucatinib to TDM1 versus TDM1, that is the standard of care today. And this also is still ongoing. And there is another trial, Astefania, looking whether if you add immunotherapy for those patients with residual disease, add immunotherapy to TDM1, whether you can improve the outcome compared to TDM1 alone. So there are different strategies here for escalating therapy. I think in the residual disease, we need to improve it because this patient population, they do badly, but you need to try to improve with new drugs, new antibody drug conjugators, or a new strategy to combine double blockade like with tucatinib TDM1, and this you are awaiting the new results.